Hi everyone, I'm Dr. Faisal Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisal and Friends, where we believe access to primary care is a right, not a privilege.
Faisal and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, I'm talking to Michael Kopko, CEO of Pearl Health, about striking the balance, moving towards value-based care. Let's get started. Hi, Mike. It's great to be here with you today.
Great to be with you, Dr. Dan, and I'm glad to be joining you on a Friday.
Yeah, absolutely. Absolutely. I feel like I'm not a very well-traveled person. Dr. Syed's not able to be with us today because he's taking his family on a train trip from Florida to New York over to Los Angeles. And I think he's probably in LA about now. And I know you recently just took a road trip from, I think, New York all the way to Miami, didn't you? Isn't that what I remember last time we talked?
We did. Yes. Good memory. We did 2,500 miles. We stopped in Richmond, Chattanooga, Nashville, all kinds of places along the way, met over 20 practices that we think are going to do great in value-based care. We met top thinkers in value-based care and had about a third of our company come out and get on the caravan. So it was a great drive for better care and a great opportunity to bring awareness to the important role of primary care in our healthcare system.
Great. We usually like to start with a question, but I'm going to start with, I got a text from a friend of mine from residency last Sunday, and I'm going to start with that, and then I'm going to let you respond to that if you can. So the text was, okay, I still don't have a great handle on how ChenMed works at the detail level, ChenMed being a full risk value-based care organization, maybe because of lack of time and survival mode. I'm sure there is more wisdom that would help me work smarter and not harder. Balance, leadership, and commitment to mission is professionally is difficult to keep in its proper place with spiritual health and family responsibilities. Every day when I pray alone in the morning, seeking guidance from God about how I use my life and talents, the spirit of Louis Barnett is right there with me. Dr. Barnett was one of our mentors. And I pray for this country, the spirit and mission of family medicine and the gospel of family medicine that was in my heart, in which David's loss and Louis Barnett kindled into a flame. Every one of you that I was privileged to walk with in Charlottesville left a price deposit in my heart and my vision, and I thank you for that. And then I called him, and it's a Sunday. He's been there all day. He's 9 days behind, and he's charting. He's in a traditional fee-for-service primary care practice that is doing some value-based care, and he was telling me there's some company that they were looking. It's not Pearl Health, but there was some company that they were looking at hiring to help them, and he was a little bit skeptical about what an outsider could do to help them. And I know you're helping doctors are hurting right now, and I know you all are working on that. So what would you say to my friend if you were able to talk to him in person about what Pearl Health could do to help him?
Happy to. And the first thing I would say is I would acknowledge some of the concerns and challenges of primary care, because I think we all know we have overburdened such an important talent set with a lot of administrativia, a lot of hoops, utilization review, and denials. These are the folks that care about taking care of patients best in the country, them, their nurses, their physician assistants. This is where good healthcare begins, and we've made it too hard to practice and increasingly financially impossible to be self-sustaining. So first, I'd acknowledge the challenge. To answer your question directly, Pearl Health focuses on lifting those practices out of what we can see as a kind of an emerging hamster wheel of reimbursement models that don't make sense anymore, and moving more toward an impact and an outcome. Everyone uses the word value-based care, but really what we're doing in a nutshell is we're taking responsibility for the outcomes of seniors across the country. We manage over 100,000 now, and we are on the hook for their medical outcomes and their cost of care. And we help primary care groups move into a model where we're leaving the visit. It's no longer how many visits can you get done a day. It's how many people can we serve, and how do we do that at scale? It's not about a one-to-one model only anymore. It's about communication. It's about getting people the right appointments. It's about avoiding things that are unnecessary. We know when someone's going to go to the ER. How do we help avoid that? We know when someone stops taking the medication. How do we avoid that? We know when someone's having a diagnosis come up as a result of specialty visits. How do we integrate that into a primary care model that enables the primary care practice to assist? And so I think that's the direction that healthcare is taking more and more. It will continue to work. So I think anyone who tells you this is going to be easy street is lying. However, I do think the nature of that work is changing in a more meaningful way. And as we allow computing to automate more of the work that we normally required people to have to do, I think we can move people to top of license so that they can really have deep impact on their patients and not spend most of their time in paperwork.
Right. And that was one of his frustrations. He used a laptop computer to take notes. And when he was in medical school in 1984, he knew somebody at HP that got him people weren't walking around with laptops in 1984 for those of us who are old enough to remember that. And so he's been very computer literate through the years, but now he's feeling like the EMR's forcing him to just put things in specific areas, but really is not adding any value. It's not like you ever come back and get that information back out of it. I've had an opportunity to look at your website a little bit, and I know you're doing some interesting risk stratification and data visualization to help people see their entire population, because that's sort of what's different about the value-based care model, the population health model, right? It's not only how you take care of the patient in front of you, but it's how you get the right patient in front of the PCP and how you maybe send somebody out to help take care of the patient who can't get in. Can you talk a little bit about how that works in your model? It looks very interesting when I look at it on the web.
Well, I appreciate that. And I think, in a nutshell, when you move into kind of a population health or a value-based care mindset, you're taking care of a community. And every physician knows that the people that need help are not the ones that are always in their office. We're grateful when they show up. It's important. It means they're saying something to you. But if you're really taking responsibility for a community, you have to go out and reach out to people proactively. And I think that's one of the great unlocks that the United States healthcare system will and can achieve. We have all the data. We know when something's going to happen. We can anticipate it. Data science, advanced intelligence models are all there. We have great providers. So as we kind of connect what's about to happen to these great providers, and we start aligning payment models and reimbursements to avoiding unnecessary illness, unnecessary events, that's when I think the system starts to get really smart. So all of our advanced analytics, all of our websites really trying to communicate a very basic thing, that we take all of this data, millions and billions of megabytes of it, and we basically condense it to a very simple system that says this patient is likely in need and we should reach out, or we should get them involved in a care flow that they are likely not going to have today. We should get them a prescription. We should call them because they're likely to go to an ER and offer urgent care and appointment. And that kind of those basics, as simple as they sound, can really reverse a set of unnecessary costs and a set of unnecessary conditions, because we're starting to be anticipatory, preemptive. And most people, they didn't know the U.S. healthcare system. They think with all this money and all this technology, we're doing that today. The reality is we're not. That's the sad part of the story. We're broadly waiting for mom, dad, grandma, grandpa, ourselves to fall, get sick, be in a hospital, be ill. That's when the money comes. The value-based care future, we think the reimbursement future of the United States is going to say, we're going to compensate you for avoiding those moments. We're going to pay you for avoiding unnecessary condition exacerbation and for avoiding unnecessary medical costs. So that's the system we're building, and we're helping now 2,000 providers, primary care doctors participate in that program.
Well, and I know at ChenMed, not long after I joined the company 7 years ago, we have smaller panels at about 450 patients, and we implemented a risk stratification. And one of the PCPs was telling me, well, I don't need that. I know my patients. And I'm like, well, just humor me. Let's look at this list that says your patients are the highest risk. And it was based primarily on medical spend at the time. It's obviously much more advanced now, but we just pulled up the page, and of the top 10 patients, she didn't know 3 of the top 10. She's like, well, I don't think I've ever seen them before. And I'm like, well, they're attributed to you. They're they're eating a lot of money right now. So maybe we need to figure out how to get them in. What do you think? And I think that was an aha moment for her. But sometimes, what was it Yogi Berra said? The problem with common sense is it ain't so common. So how do we get that common sense to the front line where it needs to be there?
Yeah, I mean, I think, and we deal with all kinds of physicians, so you have to deal with all kinds of mindsets. But, that question, if you're more of an analyst or a scientist, is actually an impossible question to answer. Like which patient needs the most or is the most important to get attention to today? You could almost think about that for the country. There is a patient in the country that needs an intervention right now. They're the one we would prioritize if we're all paying the bill and we all want to avoid unnecessary loss of life. That is an algorithm from my point of view. I don't really think humans should walk around knowing at that moment in time who that is. Now that's a mindset, and we can't disabuse everybody of that. Some people will stick to that mindset for their career. But I think in terms of the progression of technology and what we've seen with a lot of modern technology is by integrating a lot of information, we can get to better decisions and better allocations of clinical time to avoid unnecessary loss of life and unnecessary medical expenses. And your comment about ChenMed, there is a smaller panel approach to that, but there's an alternative version which doesn't necessarily disagree with that, where you take responsibility for a lot of patients, 5,000, 10,000. You leverage a physician, nurse practitioner, physician assistant, automated messaging, transport, appointment availability with specialists, mail order drugs. And so we're not there today, but just at a vision level, a couple primary care docs could maybe manage very large panels if they're properly leveraged. And I think a lot of our physicians are very interested in the future of that type of a model, where they can really use their intelligence, their pattern recognition, their patient bedside to address those kind of very key moments in patient care, but then help us all move from a mindset, which I think has plagued healthcare for too long, that clinical progress is a one-on-one visit. And that's not, it's important, but it's not categorically the only way. You can use content. You can use sequences of communications. You can use group discussions. There's all kinds of ways to deliver better healthcare besides just having a visit. And so we want to start pushing the boundary of that one-to-one paradigm and move to one of a community paradigm more and more.
Right. And I know you're working on moving to a more capitated model, and that gives you some of the freedom to do those things. Again, and I don't mean to, I should have probably brought my friend on, and I won't use his name because I didn't ask his permission. But one of the things he told me was, again, he was in computerized medical records much earlier than most of the rest of us. And before meaningful use, he was in a research network, a nationwide research network. And he realized he was only at about the 80th percentile for his diabetic management. And he felt like that wasn't good enough. So he implemented group visits, and he got up to the 99th percentile. But then meaningful use started, and now he feels like he has to spend so much time chasing those numbers that he's not really able to identify the problems that his patient population in rural Tennessee needs to be addressed. He's being forced to meet measures to get payments that may not be necessarily what his individual patients need. And I think by having the capitated model, that's going to eventually give you more flexibility to do more group visits, right? To do more home visits, to do more. If you feel like you need to pay for an Uber to bring somebody in, you don't have to worry if Medicare will pay for it or not.
Yeah, and I would say, I led your last point, even more importantly, will often pay for it. So it's not even about that capitation. I've learned, having been in healthcare now for almost 15, 20 years, certain words are trigger words. Capitation's a careful word for some folks. Risk is another big word, value-based care even. What I think matters the most for us is a world that compensates more and more for avoiding unnecessary illness, unnecessary medical expense, rewards and reimburses for health, for doing the right thing. Every payment model is imperfect. The question we're always asking is, are we moving to a better place? I think with certain fits and starts, 2 steps forward, 1 back, the models that we're in broadly do that. There are a couple of big elements to it. One, for primary care, it gives a right and not an obligation for them to convert all of their patients into these payment models. They gave it to primary care for a reason. You could have done hospitals. You could have done specialists. They could have allocated as they saw fit. this is a real hat tip to the importance of primary care in our future. And so we like that about the models we operate in ACO REACH, MSSP to a lesser extent. The second big thing, and you talked about the measures, I do think a lot of healthcare reimbursements have been teaching to the test far too much. If you look at MIPS and MSSP, it's broadly unassociated with better outcomes, meaning we have a lot of people fill out a lot of forms and do a lot of analysis to get to a quality reimbursement that has no impact on a patient. Teaching to the test, they call that in school. The new model REACH doesn't do that. It really focuses on total cost of care. It is imperfect too, and we can criticize it as much as we can compliment it. But what I really love about it is that this focus on how do we lower the cost of care for us all is a critical one. And I'll add one comment and then pass it back to you, Dr. Dan. People really have all these other quality measures they talk about a lot, and they're important, and that is not lost on us. But I think in healthcare, it's also not acknowledged enough that when you lower the cost of something and keep the quality the same, that is a massive quality improvement. If you're out buying a gallon of milk for $5 and I say I can do that same milk for $2, you are much better off as an individual, as a household, as a community. And so a lot of what we believe the next chapter of good value-based care is how do we get the same quality of healthcare to people for less? And that will then lead to the next question is now we have more, what can we do with it? But our problem is we're spending all of it in that kind of treating at the last minute, an exacerbated condition that hasn't been properly intervened and treated with the most expensive resources, and then we're not getting the bang for our buck as a country.
Yeah. If Faisal were here, he would say we're providing primary care in all the wrong places. When you go to the emergency room and you're getting a $5,000 bill for something that could have been managed in the office a week ago for $200, that's just not a good return on investment for the population here. So, and I don't want to go away from this completely, but one thing, obviously, it looks to me like you're in New York City. It looks like I'm seeing a skyscraper behind you out the window, and you're obviously a very smart business person, but you're very passionate about primary care. What's the story? My guess is you're like a lot of other people in healthcare. You could have made a lot more money doing something else. What's your story? What got you excited about healthcare and primary care specifically?
Well, I would say there's a long version and there's a short version, and I'll kind of go to the short version because I know your audience wants to get through a bunch of this in terms of questions. I became very interested in genetics when I was young, and I really believed in the power of medicine to deliver better outcomes for one's life. And then I took a detour in the finance world, to your point. As I was at Oscar Health helping build their networks, it became abundantly clear to me that access to primary care and doctors was the number one driver of patient satisfaction. And I'm very grateful for all the relationships I have in hospitals. Nobody cared about that phenomenon, meaning while it was true, there were no reimbursement dollars that would flow to primary care, and primary care was a true afterthought in the insurance network building delivery of commercial healthcare in this country. And I always thought it was odd that the thing that drives the most value is the most disrespected. And so I was waiting for a moment where this kind of insight of how do we get doctors more involved, more aligned, more patient-facing, frankly, more the face of healthcare. When you ask what is healthcare, most people, if they know the dollars of healthcare, are going to tell you it's United Health. And maybe after that, it's some major hospital chains. And we need all these groups. This is not a fight against these folks. But that is the opposite of what makes people happy. If you just study satisfaction in healthcare, it is time with physician. And so I've been waiting for a model that inverts it, and we start going where gravity naturally takes us, which is how do you build a system where people get to interact with their physicians? You can anticipate things before they happen because our system is backwards, and that's a nice way to say it. And so you start avoiding things, you make them automatic. And so I'm a systems guy at heart. And if I were designing this system anew, if you kind of gave me all power, and I shouldn't have that. I believe in the democratic process and all of that. But if you had kind of real power to design the U.S. healthcare system, I think you'd really start with how do we get physicians, nurses, physician assistants directly interacting with patients? How do we feed them tremendous amounts of information on those patients? How do we reward them for all the incremental benefits they do when they do the right thing? How do we anticipate all of their prescription needs and get that delivered automatically? You design something that's very, very different, very efficient, very omniscient. And I think this is the best shot at that. The work we've chosen at Pearl is the best way to bring that to bear. And so that's why I'm passionate about it. And that's why I'm doing what we're doing. I think it's a big systems opportunity, and it can lead to deep impact. There's a whole money side of this. But, and we live in a financed world. We have investors, so I have to talk that way. But the secret, the thing that I really can't wait to publish at some point is how many lives and life years does these systems save? Because I think that is the real beauty of it. And it's amazing if you can work in a business that can produce a financial return for everyone involved and saves human lives. Like that's the win-win of meaningful work when people think about what they want to do with their time on Earth.
Right. And I would agree with you. I know nobody's ever done this study to enough detail at ChenMed to publish it, but we're fairly confident that patients who engage with us for a significant period of time, meaning, 5 years or longer, are probably adding close to 5 years to their life expectancy. And I mean, if you think about what you could bring to market down on Wall Street near where you are, which you could bring to, if you had a drug that was adding 5 years of life expectancy, think what that would be worth. I think I heard on somebody else's podcast this week that CMS is now estimating, or Health and Human Services is estimating, that the cost of healthcare in the U.S. will go up to $8.2 trillion by sometime in the mid-30s. So that's basically doubling from where it is today.
In the 2030s, yeah. I think in the next decade, we're seeing a compound growth of a current $4 trillion base. It will double. And, and I don't mean to interrupt in terms of your question, Dr. Dan, but I would say, more as kind of a private sector person. I'm not a government service person at this point in my life. If you told someone the United States average lifespan 79 years old, developed economies are in the mid 80s, so we're losing something like 5 to 8 years of life, and you told them you have $4 trillion to solve that problem, I know we would get better results. And so that's kind of the big motivator. Is I don't think we have a money problem in healthcare. There's an alignment and incentives problem. There's an interoperability and data problem. And I do think there's a big reimbursement challenge that we need to start compensating for people who keep people healthy as opposed to wait for illness. The most dollars in healthcare goes to end-stage renal disease or oncology. And so, some of that is completely uncontrollable. But as an economist by background, when the dollars support disease, you're going to see disease. And if we can find a way to have the dollars support health, you're going to see health. And so we believe in payment models that invest in health. And we want to see more of that when we think 10, 20 years out on what the right designs are for our country.
So how do you, if you're working with a practice and probably there are very few practices that are full on fee for service now, but most are probably in a primarily fee for service reimbursement. There is some hybrid. They're getting some quality incentives or something like that. So they're paying attention to HEDIS. They're paying attention to STARS. But what's the first step moving towards value? I mean, when you work with a practice, if you were working with my friend, would you just go in and say, we'll help you and we'll put you in ACO REACH and you'll start taking full risk, and all the birds will chirp and the sun's going to rise and everything's going to be beautiful tomorrow, right? There's a lot of work to go from the full fee for service to value-based care, right?
There is, and nothing is ever simpler than it is said. And I'm someone who helps us generate a lot of new partners. And so we tend to be pretty honest about this. I think we have built a system that is the simplest, but this is like if you're kind of building a new routine at the gym, or you want to build a new muscle group or start learning how to be flexible, you've got to be committed to it. But in this modern day and age, there are a lot of help and supporting structures that can make it as easy as one can be when they're committed to making a change. And so to be very practical about that, for Pearl, to get started, it's really easy. You just say, I want to do it, and you sign an agreement. And then we ask for a bank account so we can wire payments, because we're going to now pay you differently. And we already start getting all of your claims data. So we ask either to kind of sign in on a website or we integrate with your EHR. And then what we will do is send patients that we think need attention in rank order. The most, that hard to answer question that we're always working on. We believe this patient is important to address right now. They're ready for discharge from the hospital. We got an ADT feed. They're ready for a discharge. Can you make contact and book an appointment so we don't get a readmission event? Can you see them and make sure, based on your kind of clinical expertise, they're not going to go back to that hospital? How to do that excellently? That is, to your point, it's a little bit harder. But if you break it down simply, can you make a phone call? Someone on the team typically can do that pretty easily. Working on ways to automate that part of it. Can we send a text message? Can we dial for you? We're trying to make it always simpler and more convenient. But in a nutshell, were you willing to make that kind of contact event for 2% of your panel? So, 10 to 20 of those people a month or something like that, depending on the size of your panel. And do you think that's important work to do? Do you agree with that work? If you don't agree with it, well, we have a discussion. But the next thing may be we think someone's going to go to the ER. They stop taking the medication they're on. We've watched this patient in the past. When they do that, they go to the ER. 50% of the time, they go to the hospital after that. If you can intercept that moment and either get them back on the drug or get an appointment or get them to urgent care, we might avoid that whole sequence. Again, it kind of goes to basics right now. Contact work, maybe an appointment. Maybe there's some discovery. Why aren't you taking the medication? I can't afford it. I've got 4 medications. I got too many I'm taking. I'm tired of it. It wasn't delivered and they won't reauthorize it. So there's little things that you do have to solve. So I don't want it to sound like easy street all the way. But when you actually decompose it down to its basics, it's the right kind of work. We have very little debates in terms of I don't agree with what we're doing here. It's much more how do we start doing this with more velocity and less friction? And that's kind of what we spend all of our computer science and product time on, is how do you start making this more of a supervising environment as opposed to requiring any kind of real staff work, if that makes sense.
Right. And I mean, it seems like a lot of times when you have administrative people involved, the idea is maximum efficiency with a schedule. So you want a full clinical schedule. But it appears to me with what you're talking about, when one of those alerts come across, there needs to be a little wiggle room in the schedule so that somebody can pick up the phone and call Mrs. Jones and say, Mrs. Jones, it looks like things are not going well. We need you to come in so we can take a look at you, and then give her a good experience when she comes in, rather than bringing her in and letting her sit in the waiting room for 2 hours. And then she gets frustrated and drives herself to the emergency room or goes back home and waits to decompensate.
Yeah, there is a capacity and kind of utilization strategy discussion to have here. And, I used to work at a place with a guy named Ray Dahl, who used to say between a bad now and a good tomorrow is a process of working through it. And the working through it here is, it might make sense if you are running at full capacity, which not all practices are, but some are, to your point, to think about creating some room to engage people who we're going to help avoid a hospitalization. Now, there's two answers to this question, which I think are the same ultimately, but there are mindsets in healthcare. One is, would you make extra time or would you move your patients around if we could avoid someone going to the hospital unnecessarily? Almost every physician I know and work with would say absolutely. I don't have that time maybe, but they would, in terms of the right thing to do, it's a no-brainer. The other version of it is, it's a little more financial, so forgive me, but it's important because primary care is a tough business to run, is if we avoid that hospitalization, that's $20,000. We capture at least half of that as a partnership. So $10,000 have been freed up. That is days of appointments in terms of the reimbursement trade-off, right? $10,000 is 100 visits thereabouts, 30 visits a day. There's 3-4 days of work you could not have to do theoretically to capture that avoided hospitalization event. So we believe, and again, the working through, it's an important word to use, but as people see these dollars flow and connect, they will start changing a little bit how they structure their days. When you're in the fee-for-service world, you have to do 30 visits a day to keep the lights on. In a world where you can spend 10% of your time, capture 30% of the value, you may not have to run that way, or you can run that way but earn a little more. And I think that's a trade-off that everyone gets to make for themselves. But that's kind of the strategy discussion that we have.
Have you found it's interesting that you bring that up, because when I first joined ChenMed, I got to ask Dr. James Chen, the founder. I'm like, I came from the fee-for-service world and, 2,000 patient panels, and I'm come here and I see 400 patient panels, and I'm like, is this really the right answer for a population that needs primary care. And he had very well thought out answer that they had looked through the years, and when they push the panels much above 450, they actually see increased hospitalizations and increased medical costs. And again, we focus on going into areas where there are high density, low income, underserved seniors. But I'm just wondering, are you seeing that in a less sick model? Is there a place where you cross a threshold, almost like in medicine, we would call it a Starling curve, I guess. In economics, don't they call it a Lafleur curve? You go too far and things start going down. That where the panel size gets too big, you start having problems. Are you seeing that?
I think at the essence of the question, yes. If you overburden a physician group or individual, they no longer do the things that you would in a right-sized system see. What I would say in terms of what Pearl's unique application and technology is focusing on, and we respect those limits, what we're trying to do is frankly expand the capacity. And people have been in healthcare, there's nothing new under the sun. What I would argue is if you properly enable and leverage a physician team, and we see some regulatory release where computers are going to be allowed to replace some of the human work that we've kind of historically required a person to do, I think that the amount of patients someone could serve could change, frankly, dramatically. And I'd add a third piece, which has not really been built out yet, and I don't think Pearl's going to do this in the next year or two. There's more of a medium to long-term vision, where if you can get outside of the one-to-one paradigm of clinical care and you can start communicating to patients intelligently about what's happening with them and using their loved ones potentially to be engaged in the process, there is a world, and I'll kind of give an example of it in a second, where you could serve, frankly, like almost there's not a limit to that number, but you'd have a very different system, and not even current regulation might allow it. So I want to be very cautious about what I'm saying. But part of the world that I think America represents is if you don't dream it, you'll never make it happen. So we got to kind of spend time on the vision side. But it's around making sure if you know everything happening with your patients and you know what's going to happen to them next, and you can use appointments and communications like text message and video and transport, and you can sequence all of that, where someone who misses a medication, it is offered to them to be automatically delivered to their location with a specialist appointment booked and them being transported to it, or a loved one engaged saying, this has happened to your loved one and can you help us get involved in it? You can at least start to envision a world where it's not how many visits can a doctor do every day. It's actually how intelligent is that system? Is that a smart system? Does that work? When I experience that as a patient, do I talk like that chatbot that I really hate? Or is that like, wow, this is amazing. I just missed my prescription and someone's offered to bring it to me at my home tomorrow. I believe we're going to get to that system. And so we are building for that, but I think it's going to take time, and healthcare always goes slower than we'd like it to.
Right. And I agree that sort of wasn't that one of the issues with that Simon Sinek talks about with TiVo, that people felt like if it was going to start learning what I was watching on TV, it would seem a little bit creepy, except we all interact with the internet and interact with, the New York Times shows me articles that they think I want to read when I log onto their app now, and we don't think it's creepy at all. So we got to figure out how to get around the creep factor there. So we're coming pretty much to the end of our time here. You mentioned you love dreaming, so I'm really going to ask you to dream this time. So if you had a magic wand and you could make 3 changes in the U.S. healthcare system tomorrow that would improve care for the patients and for their providers, what would those 3 changes be?
It's a great question. And I'm going to say my answer with humility, because I think as I learn more, I'll keep updating it. But I think, for me, it's pretty clear. The first thing is I would find a medium to long-term change in how we reimburse for healthcare to pay for health. If all of the actors in healthcare knew they were going to get compensated for keeping people healthy, people would be healthy. And we can kind of go through the playbook underneath that, but I would really start without leaving anybody in the lurch, converting how we're going to future compensate healthcare workers for delivering healthy patients. The second is some, by and large, focus on removing 80% of the administrative burden of participating in the healthcare system. There are some broad brushstrokes that might be considered aggressive, but I think are important as it relates to licensing, reporting, utilization, and review requirements and make it much simpler for people to be able to engage and provide services in the system without having all of the bureaucracy and regulatory review of it. And I appreciate that people have different views on that, but I think it's very expensive to just be in the healthcare system. And there's a lot of gunk work that people don't appreciate. And it's very hard to punch it out. The third piece, I think, and this is more of just at a pure population health level and, what I want for our long-term future. Most studies show that childhood health and maternal health in low-income environments has the highest ROI. And I'd ask us to go and double click on how we're spending, because if we are willing to really play long ball, the multiplication of dollars, if properly delivered to low income and frankly just children in general and their mothers, has the most powerful return for us as a country. And there's a friction of, well, who's getting less versus who's getting more. But if you really think broad enough, you can properly invest to have a lot less having to be spent out later because of how powerful certain changes are around nutrition, preventative care, good care delivered around the child.
I couldn't agree with you more. That sounds like we would live in a much more just world if we could give you your magic wand and let you change the system. Michael Kopko, thank you for being with us. Thank you for sharing your passion and the work you're doing with Pearl Health with us today.
Appreciate being on, Dr. Dan. Thanks to your audience, and hope you all have a great weekend.
What are your thoughts on striking the balance, moving towards value-based care? You've heard ours. Now we want to hear yours. Email us at fasilandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Fasil and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Fasil.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.